Hey everyone, this is Soph, and you're listening to the Beyond Pain and Fatigue podcast, where together we'll explore the complexity of chronic pain, fatigue, and invisible illnesses. Hi everyone, and welcome back to another episode of Beyond Pain and Fatigue. I am super excited to have fabulous physiotherapist Sharon Hennessey joining us today. And thanks so much for joining us, Sharon.
Hi, how you going, Soph? Good to see you.
You too. By way of background, for those of you that don't know Sharon, she is a leading physiotherapist, educator, and advocate who's dedicated her career to changing how hypermobility is recognised, understood, and treated. Sharon graduated with a Bachelor of Physiotherapy honours from the University of Queensland in 1997 and has since delivered more than 15,000 physiotherapy sessions across hospital, rehabilitation and private practice settings in Brisbane, London and rural Australia. She's the founder and principal physiotherapist of Not Just Bendy Hypermobility Services, which is a clinic in Brisbane dedicated to supporting patients with hypermobility spectrum disorder, Ehlers-Danlos Syndrome and other connective tissue disorders involving symptomatic hypermobility. Under her leadership, the clinic has grown to a team of 10 clinicians and was recognised as a core network of excellence by the Ehlers-Danlos Society in 2024. Sharon's clinical expertise spans across physiotherapy in areas including neurorehabilitation, musculoskeletal practice, women's health, rheumatology, paediatrics, and chronic pain, experience that gives her a unique ability to see the multisystem complexity of hypermobility disorders. In recognition of her work, Sharon was named Physiotherapist of the Year 2024 at the Allied Health Awards. There is so much more I could say about Sharon, but let's just leave it at I'm very glad to have you here today and very keen that we're going to be able to pick your brain in this area. So thanks again for joining.
Yes, exciting.
So I guess to start with, this is something that I think we're seeing more and more. And, you know, I think typically these are conditions and experiences that have often gone very under-recognized. And as we're starting to talk more about it, I think one of the things that I've noticed is there's sometimes a lot of confusion around the different terms that might get thrown around and how we're actually sort of describing what we're talking about. And I think one of the common ones that I see is the question about when we're talking about hypermobility and hypermobility disorders, generalized joint hypermobility, hypermobility spectrum disorders, hypermobile EDS. I guess, how would you sort of explain the differences between some of these terms we see and how we distinguish between them so that we can be a bit more clear in what we're actually talking about?
Okay, yeah, big question. I think the problem comes because over the years, um, how we define hypermobility problems and what we call them keeps evolving. So basically, back in the 60s, the geneticists started to notice a group of connective tissues issues that they labeled as Ehlers-Danlos Syndrome. And then the rheumatologists at the same time, in a different field of research, started to notice hypermobility-based conditions that were causing people problems. And so then there was two different words for it. There was this Ehlers-Danlos type 3 that then became Ehlers-Danlos hypermobility type. And the rheumatologists called their one benign joint hypermobility or benign joint hypermobility syndrome. Now, the word benign now has been misinterpreted over the years because when they said benign, they meant a type of hypermobility that isn't going to cause you loss of life. But it's been interpreted now as, well, that's just a benign thing. It doesn't cause you problems. So then in 2016, pretty much 10 years to next week to the day, everyone got together in New York. I went for this meeting and discussed all the findings that all the consortiums had come together to try and decide what we're going to call it and how we're going to define it. And that's when we got the current classification criteria for hypermobile Ehlers-Danlos syndrome and for all the different types of hypermobility spectrum disorder. And I think one of the biggest common misconceptions we have now is, well, if you've got EDS, that's considered significant. Or if you've got HSD, then it's not as severe. But really, these things exist on a spectrum. And it's very difficult to distinguish who may happen to get on or who happen to not get on based on the criteria. So I think when the criteria were made for hEDS, it was basically to distinguish hEDS as a specific group so they could try to do research to try to look for the genetics factors involved. So they were really looking for that more common family history and, those connective tissue signs outside of the joint pain. And I think that we're looking at getting new criteria towards the end of the year. And I think there's going to be some more give and take on those criteria again.
Absolutely. And I think just even talking about the diagnostic piece there, there's been so much evolution, and the criteria is very much being that clinical criteria because, as you touched on, there isn't yet a genetic marker that we have for hypermobile Ehlers-Danlos. And I guess knowing that a lot of people who might be listening may not be that familiar with Ehlers-Danlos as well, there are obviously many different types.
Yes. So the Ehlers-Danlos syndromes, and I don't even know how many there are at the moment. They keep changing. It could be 12, it could be 14. They're going to find more subtypes as we go. All the other subtypes, such as classical, classical light, vascular, kyphoscoliotic, they all have a genetic marker and more specific signs outside of the hEDS criteria. And they're very rare. So in our clinic, we probably see, you know, 3 or 4 of these clients a year over thousands and thousands of people who visit. So in that respect, we've got another confusion because a lot of medical people have been trained at university that hypermobile Ehlers-Danlos syndrome is very rare. So most of the research is still sort of saying 1 in 5,000 people meet the criteria. It's probably a lot higher than that, but we just don't have those specific studies showing that at the moment. Certainly in a small town, of a couple of million people like Brisbane, there definitely seems to be a lot of people reaching out for management. And we've only really hit the tip of the iceberg of who's actually worked out that they may have a connective tissue disorder, if that makes sense.
Yeah, it
Yeah.
always makes me giggle when I hear people say, "Oh, a small town like Brisbane," like being from Wagga. But yeah, I would see that, even out here, in particularly in regional and rural areas where we, generally would have less workforce than in the city. So just accessing any care is a problem. I think that under recognition and under diagnosis is a huge problem, and people just aren't getting through the pipeline. So I would agree with you. And similar to you, my caseload, I would say, is probably 60 to 70% hypermobility related sort of cases. And of the entirety of my practice, I think I've had 2 classical and 1 kyphoscoliotic. And,
Yes.
and that's, over the course of everything I've kind of seen. And I think the estimate is about 90% of all EDS presentations are probably in that hypermobile subtype,
Yes.
right?
Well, at least. So
Yeah.
when they did the hedge study, they took, biome and genetic samples from 1,000 people with hEDS, and it came back there was, of that 1,000 people, there were 7 people in there who were actually a different subtype and had been missed. So
Mm.
it just goes to show that so that's less than 0.007%. So it just goes to show that the clinical criteria are quite useful still at distinguishing from the other subtypes.
And so, in that, knowing that, heads is sort of a big chunk of the EDS cases we might see in practice. And then it's particularly heads where we start to have this sort of blending into the hypermobility spectrum disorders or HSD, and where it starts to get a bit unclear. I guess a question that I often get from physios a lot, and I'm interested in how you explain this. There's often the statistics and I guess the general awareness that just within the average population, joint hypermobility as an isolated symptom is actually reasonably common and often asymptomatic, I guess, a fair chunk of that. How do we differentiate between people who may have joint hypermobility versus those who might have what we would consider a hypermobility spectrum disorder or hypermobile Ehlers-Danlos? What's the difference there?
So, I mean, the research is it differs across ethnicity, but basically it's around 20% of a Caucasian population that would have signs of hypermobility now or in the past. So we can look at the Beighton scale, which is the 9-point scale looking at a range of joint movements. And that tells us whether we consider someone hypermobile based on the standards. Did you want me to run through that, Sophie, just to
Yeah,
remind everyone?
nice and quick.
Yeah, nice and quick. So you get a point each for if your elbow bends backwards on each side more than 10 degrees. Thumb to forearm on each side is a point, and little finger back more than 90 degrees is 2 points. Knee hyperextended extension greater than 10 degrees, and hands to floor without bending knees. So we've got our 9 points there. So if you're more than 5 out of 9, you sort of fit into that hypermobility characteristic. Okay. For kids, it's higher. It's a 6 out of 9, and they may be changing some of these again with the new classification. The other thing we can work out if people are hypermobile is the 5-point hypermobility questionnaire, which is a really easy one to screen in clinic. Okay. So you only need 2 or more of these as positive to be considered as likely to be hypermobile. Okay. Or in the past. Could you ever touch your thumb to your forearm? Do you consider yourself double jointed? Have you dislocated your knee or shoulder? Could you ever touch your hands flat to the floor? Could you do the splits or have party tricks? Okay, so I suppose those 2 things. If you've got a button more than 5, then technically you're hypermobile. If you don't get 5 or more out of 9, but in the past you can answer those questions and get more than 2, then you were probably hypermobile before. As I suppose how you live your life, your connective tissue changes over the years, and injuries that you may collect and the amount of movement that you do is going to also change what your joint range of motion does. And so that's why there's that. So that's 20% of everyone. When we start to get into symptomatic hypermobility, we start to look at when people are actually getting problems from it. So pretty much most Olympic athletes are hypermobile, swimmers, javelin players, tennis, obviously gymnastics, divers. There's just so much hypermobility in the world, and it can be used advantageously for a lot of people. And then we're looking at when hypermobility starts to become chronically painful, either chronic pain in more than one limb for an extended period of time or multiple joint sprains and strains. There's lots of little things we can pick up with that. On the EDS criteria, it also has a pain question, and it goes through some of the other things like your connective tissue, your family history, and that type of stuff. So we know with hypermobility that once people are symptomatic, they can be symptomatic in many ways. Some people with hypermobility may not have a lot of musculoskeletal pain, but may have a lot of the co-occurring conditions that occur with it. And so even those people need to be picked up and recognized.
Absolutely. You've touched on an important point there because a lot of people, I think, what I've seen in the clinic, a lot of the questions that I've gotten is, people might be starting to hear about hypermobility and go, oh, I'm hypermobile. Is that, and kind of quite concerned about that in terms of whether that's going to be a problem or whether, they're going to inherently end up with all these issues. And like you've said, there's a lot of people who might be generally hypermobile who don't necessarily end up having any problems. And it's sort of maybe considered part of the normal variation.
Mm,
But for a subset of people, it can actually start to become quite a problem and often extending much more beyond the joints and the musculoskeletal tissues. And I think that's the bit that often gets missed as well. We're
mm,
often very focused, particularly in physio land, on joints and muscles, but we kind of neglect that there's often these multi-system impacts as well. And you mentioned it much earlier, I think, that it is a spectrum. So, you might have some people who present where they have, marginally less symptoms like your subluxations and your dislocations. They're not as functionally unstable, but they do have a lot of these other things. So
mm.
everyone's very different, I guess, is
Yeah.
what we see.
The really severe presentations where people are dislocating their joints frequently or have the inability to digest food and need to be fed through alternate means, I think we can all agree that they're down the severe end of the spectrum. I think we should start to come down that road to not very severe or asymptomatic. I think it's a tricky one because I mean my philosophy pretty much when I'm talking to people out in the community and just at barbecues and talking about hypermobility, when you start actually asking people, the reality of their life, of these people who think they're asymptomatic, they might say things to me like, but that's normal, is it? Everyone's got tummy problem the whole time. And, it's normal to go to the toilet every half hour. Or, so what we perceive as normal, sometimes I think maybe masking a lot of conditions, particularly when people go ask for help. So for example, they go to their GP and they say, I'm very fatigued. And they run all the basic bloods and there's no reason for that fatigue. So then they're sort of told, well, there's nothing wrong with you. But maybe it's more, there's nothing wrong with you that we can work out right now. But how do all these puzzle pieces fit together?
Mm,
Because I think just because hypermobility is common, it doesn't mean we should ignore it. Or
yes.
if someone's only having more mild symptoms, as in they're still able to work, that doesn't mean we don't want to try to deal with things before they could possibly progress or try to halt progression at any point.
Yeah, absolutely. And it is like, it's very funny because working, I mean, obviously I work a lot in the hypermobility space as well, but my, I guess the main area that's anchored around is persistent pain and fatigue. So I'm often seeing people who are quite, I would say, functionally impaired, generally speaking. But it's amazing how often I will still see people who have kind of just internalized or not had a frame of reference, particularly if there's someone who's had pain and fatigue symptoms literally their whole life. And that just becomes your normal. And if you've never not had that, you sort of don't realize how abnormal it is until you start sort of asking questions. And that's not to say, if people can have symptoms, but it's not functionally impacting and their quality of life is still good, then, there's an argument to say that, okay, they might be coping and, how much intervention is needed for that person is always an individual thing.
Mhm,
But
mhm.
there are a lot of people who are actually very functionally impacted, but they just actually don't realize how much like it is not normal, or I think importantly, how much they might be able to actually do to help improve their experiences as well. And that's the thing.
Exactly. I think that's the thing, is that even those people who seem to be able to work, I mean, I see it at work all the time because a lot of my staff come to me because of interest in hypermobility. And I see with them when we start actually just treating them, even though they can still work a physical job full time, their improvement in so many parts of their lives is very apparent.
Yes.
So I think there's always stuff that can be done. And I think minimizing people who are down on a different part of the spectrum, I find that a very difficult thing to do because a lot of the time when I'm talking to, colleagues that I'm trying to educate about this, there may be this idea that, well, yes, there's these severe people and then there's a whole bunch of other people that just want to do this because it's the latest craze. And
Mm.
that's the part where me and some other people start to differ in our opinions.
And that's the hard thing, isn't it? Right? Because you think about all of the other conditions where there's been this shift from this is now suddenly that we have this greater awareness and we're able to pick up things. And it does feel like at any time where there is a shift and greater recognition of certain things, there's a risk that we will kind of have that response, in terms of, oh, well, back in my day, no one had this condition. It's like, yeah, it's like, just because we didn't know about it didn't mean people didn't exist, right? And people weren't suffering. And that's something that I've seen a lot as well, is that people are coming in and often really struggling to find support and understanding because there's just not really that acceptance or willingness to consider whether or not this might be part of their presentation, and it sucks. It really impacts on people. I guess like part of that is the complexity, and you sort of touched on that, this multi-system impact. Sometimes people might have gut issues, they might be having other things going on that it's very easy sometimes, particularly with the way that our health system is set up, which is often very much through these like silos of specialization, that we might just be looking at one body system or one particular condition or symptom. Just to give a bit of a clinical picture of, I guess, some of the complexity and comorbidity we might be seeing. We mentioned it goes often beyond just the musculoskeletal sides of things, but what are some of the broader sort of symptoms or comorbidities that we often see when we're getting people presenting?
The first sort of trifecta or the three overlaps that are most commonly talked about is the symptomatic hypermobility or hEDS, depending on what research you're looking at, and POTS
Mhm.
and mast cell activation syndrome. So POTS has gotten a little bit more recognition since long COVID, which is great. And I think the other thing that was interesting with some long COVID research is that those who are hypermobile seem to be more likely to
Mm.
have long COVID than those who are not. So there is some evidence that people can be born with hypermobile joints and spend their whole life asymptomatic, and then suddenly something happens and their whole system starts to become symptomatic. So that could be an infection, it could be a hormonal change, a change in your load, an injury. There's lots of things that we hypothesize could do this. So with POTS, we're looking at postural orthostatic tachycardia syndrome. So this is the idea that the connective tissue in your collagen is elsewhere outside of your joint ligaments. Okay, so hypermobile ligaments are, they're normal, but they're extra stretchy. So there's more type 3 stretchy ligament component to the type 1 collagen that is a little bit firmer. And then that stretchy collagen is in a lot of places in your body. So for example, in the veins in your legs, they're extra stretchy. So when someone with hypermobility stands up, the blood pooling that goes straight down into their feet can start to bring symptoms of lightheadedness, So the body sort of says, if my blood's down in my legs and my blood pressure's dropping, I might faint. I know what I'll do. I'll make my heart beat faster to get that blood back up to my heart as fast as I can. And so that's the tachycardic part of POTS.
Mm.
So what this then means is like, so what? Your heart beats faster. But to get that heart to beat faster, we have to release adrenaline. Okay. So we're looking at the sympathetic nerve excitation. So we get adrenaline release, we get lots of other things released like cortisol. And as well as increasing the heart rate, that gives us a raft of other symptoms, such as dry mouth, such as anxiety, some gut issues. So it can speed your gut up and make you empty out, and then it can also turn off your gut secretions in the long term. So you're upright, your heart's beating really fast, you're not fainting, but just walking around and doing the vacuum might have you feel like you're running up a hill. Okay. So that can come with reduced exercise tolerance, shortness of breath, lots of other things. So that's your POTS. Okay. Then the other one that's very common is mast cell activation syndrome. Now, this is something that's very accepted within the hEDS literature, but in the wider literature of allergy and immunity, it's not really very well understood. So basically, it's the idea that a lot of hypermobile people, I call them sensory superheroes. It's a bit like the princess and the pea. You've heard that story? So there's this princess, she lies on top of 20 mattresses and she can feel a pea under all of those with her extra amazing sensation. That's a hypermobile lady, okay? So your mast cells are your normal regulators of your body. They hold thousands of chemical mediators. Now, think of them as a fire engine. So your house is on fire. The emergency team shows up with the fire hose and sprays the house and puts out the fire and saves your dog. Yay, they're heroes. What about next week when you've just got your new place organized and you're having a candlelit dinner with your partner in celebration, and then the fire engine shows up with the hose to put out your candle? It's the same immune response. It's just potentially a very sensitive or slight overreaction to what is potentially needed. So that could be a hypermobile person might run into a door because of their poor understanding of where their muscle and body is, which is called proprioception. And then they'll end up with a huge bruise. And they're like, well, I barely knocked myself. Well, that could be the mast cells releasing epinephrines for bleeding. The other place the heparins we think are causing problems with hypermobiles is with endometriosis, is with heavy periods. Histamines release when you have an ankle sprain, so your foot puffs up, much faster. So it's a longer time to heal. So, and then depending on who you talk to, the mast cell might be perpetuating the POTS, or the POTS might be perpetuating the mast cell, and they're both probably perpetuating the functional gut disorder. So it's all sort of this like, incestuous little cousin family, and no one really knows who the target patient is. But we know when they get together at a wedding, it's a bit of a disaster.
I love that analogy. And I think it's such a good way of explaining it because, and just as a side note before I forget to mention it, if anyone is interested in doing more of a deep dive in either POTS or mast cell, we've got previous episodes up as well. So we had Dr. Marie-Claire Seeley from the POTS Foundation Australia who came on recently to talk about POTS. So definitely go listen to that. We've also had the amazing Jason Lamb on to talk about mast cell activation. So if anyone's keen to kind of do more of a deep dive, definitely go there. But I think what you're describing there, and often I think what matches with what we see clinically, is you will get people coming in with just these really complex, overarching, multi-system things going on. And if we think about mast cells as an immune thing, right, that immune function, we often see lots of things like your skin rashes and gut issues and fatigue, headaches, and all of these things could also be symptoms of POTS and can also be symptoms of, hypermobility. And, you can definitely get people who might have, one but not the other necessarily, or don't quite meet the clinical criteria for the other. But the research is limited, and I think we need so much more research in this space, particularly around these intersections of these conditions. But I think to me, what it really suggests is that there is a significant component of some shared underlying vulnerability or predisposition to multi-system dysregulation between these conditions. And it'll be really interesting, I think, to see over the next sort of 10, 15 years where some of our more benchtop science gets to in terms of trying to unpack that, because I think we just really don't know. I think particularly because so many of these symptoms are very non-specific, it makes it very difficult to work out if someone's coming in with fatigue. Is it fatigue arising from this disease process, or a combination? It gets really tricky to unpack. So thank you for explaining that, because I think, yeah, the sentiment I've often heard from people, and I'm sure you would get this too, mentoring and teaching in this space, is that often when I'm talking to people about starting to learn more, it can be really overwhelming for clinicians because they sort of come in and go, oh my God, there is just so much going on. And how do I even start to unpack this?
Hmm. And I think that's sort of the basis too of our medical model, right? So the basis of the medical pyramid is get the diagnosis and then get that best treatment management for that. But we've got multiple things here that are hard to get a diagnosis on, and with huge discrepancies between different professionals in the same field as to what they think that diagnosis means and what that management means.
Mm,
So at the moment, a lot of these things I know that it's a thing. We're seeing it clinically. We're seeing over and over again that when we get appropriate medical management and get people some H1 and H2 blockers, sometimes their pain really settles down. Sometimes their fatigue goes away. Like it's just very significant. Or sometimes that doesn't make that much of a difference, but it might decrease the frequency of their fatigue crashes and flare ups. Or sometimes you need a little bit of this and a little bit of that because hypermobiles, as we know, absorb medication differently as well. So yeah, there's some recent research just out in the last few weeks looking at the epithelial linings of our lungs and our digestive tract and suggesting there could be issues there that could be perpetuating all these problems. So yeah, watch this space. Hopefully we can get some great research going on this in the future.
absolutely. And I think that's kind of coming back to when you were speaking earlier about the diagnostic process. I think it really speaks to kind of where we're at the moment, where in trying to diagnose these conditions it really isn't as easy as just having a single test we can do, because there's so much complexity in it. And knowing that we've ended up with this clinical criteria for hypermobile EDS, which, as you mentioned, is due for a revamp towards the end of the year. So that'll be
Mhm.
very interesting to see how that changes and what changes. But, at the end of the day, while informed by, very, experts in the field and through a lot of consultation, it is very much based around, I guess, a pragmatic kind of how do we kind of define this cohort in a way that is helpful, but might not be like, I don't think it's perfect, and it's hard to get it perfect when we
Well,
don't.
it's only the first step, isn't it?
Yeah,
I mean,
exactly.
people spend 20 years getting the diagnosis and then say to me, "I finally got it. Now what? No one's helping me." So
Absolutely.
so for me, like in my recent course, I'm doing some courses on this for other professionals, is it's really also that decision of who needs a diagnosis and
Mm,
how is a diagnosis, an official diagnosis of hEDS going to improve your management or your treatment. And I think that really has to be the key. There really are too many people in the world to probably end up diagnosed with this because there's just not enough health professionals to do it. But if we can have a solid management plan for this type of stuff, then we could be managed by our GPs or our primary care physicians. So, yeah, it's interesting. There's a lot. I think the new criteria have had some whispers that there were maybe some of the comorbidities or co-occurring conditions on the criteria, a bit like in the pediatric criteria. They currently mention those things that we have clear correlation on in the criteria. So I think that might then start a conversation with medical teams about management of those things.
mm.
Because if it's there in black and white on the criteria, it's going to be much harder to ignore.
And I guess on that, because you sort of touched on the severity side of things earlier around sometimes there's this misconception that someone with hEDS, for example, inherently going to be more severely impacted than someone, say, with hypermobility spectrum disorder. How do you explain to people the difference between these two? Because sometimes I think that's a really nuanced sort of differentiation, and I'm interested to hear how you describe it or explain the difference to people.
Yeah. So, I mean, it's a big one to explain. I mean, I tend to try to not focus on the diagnosis as much. Okay. So we'll do our screening for hypermobility and we'll do our full assessment through the comorbidities. I'm not going to probably go through a hEDS criteria with someone unless they're quite significantly affected. Now, that doesn't mean you have to be crawling along the floor to the toilet, but the reasons why I recommend we go down that path are things like some funding models do require you to have a diagnostic letter. Okay, that doesn't often give you access to funding, but it's a precursor. The other thing that's quite important is when people are showing up to the emergency room with recurrent problems or dislocations, that emergency room will take hEDS more seriously and you can set up care plans in that case. The other thing that I find very useful is people's got these multiple comorbidities. So it helps with communication. So say if someone with hypermobility is going to have surgery, and we know in the past surgery has caused problems due to poor wound healing or anesthetic complications. And as we've been doing this, campaign to get the word out, people are starting to understand, okay, I'll get better surgical outcomes with this client if I use a different type of suture. Okay. And
Correct.
then, of course, the other thing that's very important for getting this diagnosis is that the person really needs it themselves. If they really feel like they need that after years and years of, lack of diagnosis or understanding of what's going on, if they feel that they need that piece of paper from a specialist to say, this is what I've got, then of course I encourage them to go do that. Okay. But we also talk about what's the management going to be there, because we've all seen patients, Sophie, with the limited number of people in this country who are willing to diagnose hEDS. It can take people a lot of money and a lot of years to get a diagnosis, and it almost burns them out in the process. So for me, I'm always on about management. Okay. So we always say, yes, provisionally or clinically, a provisional diagnosis, you fit the hEDS criteria. Therefore, I think it may be worth going to see a rheumatologist. Or if they don't fit the criteria, we go, well, unfortunately, you only have a Brighton of 4 out of 9. So technically, you don't pass the criteria. But in everything but name, you have that.
Yeah.
Okay. So
Like you're presenting, and I think that's
yes.
what I often bring it back to clinically is like if people are presenting with similar symptomatic complaints, like if people are feeling functionally unstable in their joints or they're having subluxations or they've got these overlapping things, there's nothing stopping us as clinicians to go, okay, well, if it looks like a duck and it's quacking like a duck, let's do with it
Yeah.
what we would do with a duck,
There's
like that
nothing I
sort of
can
thing.
stand less than someone saying, I've only got a 2 out of 9 on my bite and therefore they're not hypermobile. I'm
Yep.
like, okay,
Yep.
just keep digging, because when you do talk to the leaders in this industry and the rheumatologists and the people at the EDS Society, everyone does more than just the Brighton.
Yes.
It's more important potentially to look at that history of presentation over the years. I mean, I'm not diagnosed, my kids aren't diagnosed, but I know how to get the help that I need without it. So I'm okay with that. But there's lots of other people who need it, and that's okay. But
Oh,
I think we just have to have a solid think about what it means to have a diagnosis, and that because it's not something there is a biologic medication for or anything like that, there isn't some magical cure that's going to happen once you get
mm,
it. Okay. That doesn't
right.
mean there's lots of things we can't do, but until we have a specialty that is focused on the multisystem aspect of hEDS, or have lots of integrated care clinics all over the country, we're just not quite at that stage.
I think that's the important bit is, what is the utility of that diagnosis for this person in their context? How is it going to have a beneficial effect, and is it needed? Can they access that support, and can we do things that will help them? What is the added benefit of diagnosis for that person? And I think particularly, like you said, amidst things like the cost and the energy and the
Mhm.
time is
Yeah.
something that's really important for us to weigh up. And you did say it before, but I'm just going to highlight it because I think it's a really important point for people in case they didn't really catch that. I think that point of, I guess, the hypermobility spectrum disorders versus the hEDS, and the way that I've often sort of described it is that obviously the hEDS criteria is that there's very strict specific criteria that people have to meet. So people might not formally meet those, but hypermobility spectrum disorder is kind of then the sort of alternate diagnosis that's considered to catch people who present in similar ways but don't meet that full criteria.
Yes.
I've often thought of it as people, it's not necessarily about the severity. So people might not have the same breadth of symptoms or the same variety of symptoms that's captured in the hEDS criteria, but it doesn't necessarily make a comment on severity. So people might be very severe in certain components of that, but not in others.
Yeah. So I would say that there is no clinical distinction on severity in any of the criteria. You can have hypermobility spectrum disorder and be as disabled as someone with hEDS, okay? Because the thing is, they made that criteria for research purposes, okay? So that's the main difference. And if you don't get 5 out of 9, you can't be it. Now, with the HSD criteria, they have made several little steps within that criteria. So the generalized hypermobility spectrum disorder are those people who show those signs of hypermobility in their joints still and also have some of those musculoskeletal pain complaints or instabilities. Then we have the historical hypermobility spectrum disorder, which is probably where I sit at the moment. My Byton has fallen to around a 3 out of 9. Now, that I wouldn't pass the HEDS criteria now, but when I was 30, I would have. So, things keep changing, right? So then there's also a couple of other things in that criteria, which is a localized HSD, which is for one joint, and a peripheral PHSD, which is for hypermobility in the hands and fingers. But those last two are certainly not diagnosed as frequently.
Yep, absolutely. And so, there's so much variability. And again, something you mentioned before that I think is really interesting is that from a functional management perspective, it really doesn't make a difference whether people are diagnosed HSD or HEDS. We're kind of effectively doing the same thing with people. Well, we're not necessarily doing exactly the same thing with every person, but it's very individualized based on their symptoms, but it's not affected
We
at
don't
all really
treat
by the
a
diagnosis.
diagnosis, we treat
Yeah.
a presentation. So I think this is the thing with physiotherapists, we treat what we see. Okay. So it doesn't really matter what the label is at the top of the page. Okay. So yes, it might matter for some doctors, depending on their silo. But in the end, once you get a diagnosis, because this is a functional and a clinical diagnosis, so you can have a look at the spider, which is a 8-point tool to show where people are finding most of their symptoms with their hypermobility. So it is a validated questionnaire. There's around 4 to 5 questions in each subsection. And then you get a score. And there's a great little website you can go to now that has it free. You can download the Excel and answer all the questions, and it will plot your spider graph. So it has things on it like pain, fatigue. No, it has, Sophie, you're going to have to help me here.
So you've got symptoms of pain, fatigue, gastrointestinal, cardiac dysautonomia, neuromusculoskeletal, urogenital, anxiety, and depression are the spider domains.
Mm-hmm. Yeah, so they're all validated, I think, in adolescents and adults and potentially in children, depending on who's doing the questions. So that's a really interesting way to sort of look at yourself. And because when you've got problems in multiple domains, it makes sense to try to find treatment for the things that are having that largest impact in your life.
Absolutely. And kind of along that same line, because thinking about clinically what might be some of the useful things we can start to think about if we're working with people who are experiencing hypermobility related disorders, are there any other outcome measures or questionnaires that you find you tend to gravitate to?
Yeah, so I think there's all sorts of questionnaires, outcome measures. I think there's not a lot in the hypermobility realm. So we've got the spider, we've got the Bristol Hypermobility Index. It's very good, but it is quite long. But we tend to use whatever's appropriate for that person's presentation. So we might use something very simple like the Karnofsky Index to get an idea of their degree of disability or function. We might look at a hEDS again to look at function across domains. If they're presenting with neck symptoms, we might just use a neck disability index or the Oswestry back index. The upper and lower limb functional scales are also very useful. And then the patient-specific functional outcome scale where you pick the issue the client has and get them to rate it 0 to 10. We sort of do on our intake survey a sort of a bit of a, hybrid mix of grabbing a few different things from few different places. So we ask a few things from the Tampa kinesiophobia type index questionnaire and the pain self-efficacy questionnaires. So we sort of grab a bit from a few different places. There's some great fatigue indexes that we often use as well. So I think you could probably give each hypermobile person around 12 indexes to do.
Yeah.
But I think if you're going to choose one, the spider would probably be a good one to do.
I'm so glad that you've touched on that, because I think whenever, it doesn't even really matter what we're talking about, whenever we're talking about outcome measures or questionnaires, it's really about, we don't want it to be a protocolized, you give this to every person who comes in by default based on a diagnosis. I think it always should be thought about through that lens of, okay, what's actually going to give us the most helpful information, what's adding value, and how are we being efficient in that? Because I guess in the context of my setting, because I am working very much in that sort of pain and persistent fatigue space, and often working with people who present with long COVID, MECFS, really pronounced fatigue. We know cognitive fatigue is also an issue and can trigger
Yes.
PEM. So giving someone PEM questionnaires probably isn't going to do them any favors
Yeah.
either. So, and really, who wants that amount of homework? Even, if you're not dealing with that, I don't think I know anyone who's happy to sit down and do, 50 pages of questionnaires. But so that's really helpful. And I think, yeah, I've found the spider super, super helpful. If we think about your context as actually, no, I was going to ask you about management, but I have one more question around diagnosis, because I think it's something that I've seen be quite topical.
Mm-hmm.
Often a question or a discussion I'm hearing being had a lot is around the role of genetic testing in diagnosis for these conditions. And a lot of people who are sort of asking, well, if I think this is what's going on, should I be referred to a clinical geneticist, or do I need genetic testing?
Yes.
Could you talk to, I guess, where the state of play is in regards to genetic testing at the moment?
Yes. Yeah, sure. So, I mean, the state of genetic testing is such that there just isn't enough people to do genetic testing on everybody. So, it's unusual for a referral for genetic testing for hypermobile people to be accepted by the current systems unless there's a specific red flag that would indicate another condition. So, interestingly, we've just launched a blog on my website, Hypermobility Project, and it's called Focused Red Flags. So this is collaboration with Dr. Alan Hakim, who's the clinical medical director of the Ehlers-Danlos Society and a rheumatologist. So when we had our catch-up, so every year the heads of the Ehlers-Danlos Society networks get together, and we're actually doing that next week, which is very exciting. And he gave us his list of the things that you would screen for. And so he's very generously worked with us to produce a handout with that information on it. So it has pictures and tick sheets, and it basically sort of, the way I think it's going to be published in the new rheumatology textbooks that aren't due out until later in the year. If you read the blog, it'll give you more context, but it's basically sort of saying, do you have any of these things? Do you have a family member, a first or second degree relative who had any of these things? Some of them are things that a physiotherapist can't answer, of course, but if some of those things come up in the history, then that's the point at which you would maybe up it to a specialist of that type of thing. So say someone had a uncle who died of a AAA under 50. Well, then that could be a sign that we would contact their doctors, look at some heart investigations, perhaps refer on to a cardiologist or whoever needs to look at those things. So I think that's, in his opinion, if you don't have any of those things, then referring for genetic testing isn't indicated. Okay. And we also had Dr. Claire Franca DeMarco look over it as well. And she agrees. So it's hard because there's no definitives in medicine. Okay. And even the ethics of putting something like this out there when it could miss someone, it's a lot to sort of consider, but I'm going to be brave and put it out there for people to access. So at least there's quality information based on, the experts in this area on how to screen and look for other conditions.
I think that's kind of the thing, because as much as there is evolving research that's trying to find a biomarker or a genetic marker for hypermobile EDS subtype, at the moment we don't have that specific, like we can't actually genetically test for hEDS because there's no marker that's identified. What we're often doing when we're sending people to a clinical geneticist is ruling out the other specific subtypes. So that's where those red flags you've mentioned come in.
Mhm.
It's like, yeah, 100%. If we're suspecting someone has that, the classical EDS subtype rather than hypermobile,
Mhm.
100% they're the people we're sending. Or if we're not sure whether there could be something like Marfan syndrome or some other hypermobility syndrome that does have a genetic marker, that's when we're sending. But, I think I think it's hard in some ways. And I think you're right, because there is such a wait list and there's not the capacity for everyone to see clinical genetics. And because of a lack of a specific test, it makes sense that we need to start thinking about, well, what's actually efficient and helpful for people in terms of referrals.
Mhm.
I can also appreciate, though, and I'm sure that from people you've seen, there is a challenge in that for a long time, because these conditions have been so poorly understood, that often people who do really need a formal diagnosis have found that sometimes seeing the clinical geneticist has kind of been their mechanism to do that, because they've been the ones to objectively rule out the other stuff and say, no, it's this. But
Yes.
that doesn't necessarily mean that it's the most efficient or helpful pathway for us to continue pushing, given everything that's going on at the moment with access. And we don't want people waiting 3 years to see someone. And it's a tricky space. I'll be very excited to have a read of that blog, and we'll
Yeah.
definitely chuck the link to it in the show notes as well.
Yeah, I think it's that final thing on the EDS criteria and the HSD criteria, which is elimination of all other possibilities. It's very hard to eliminate every single possibility. So we'll see how the new criteria stands. And I'm hoping, with education, perhaps this red flag focus tick sheet might help bring people to think about, just to confirm, the handout doesn't go through every condition it could possibly be, because obviously people need to be checked for autoimmune disease and rheumatological conditions. But it goes through those dangerous ones. We're always worried that we might miss: Marfan's, Loeys-Dietz, and vascular Ehlers-Danlos syndrome.
Having spoken a bit about the complexities of diagnosis and like the general clinical picture, thinking about then the extension of that, because we've repeatedly now said, it's really about working out what is going to be helpful for management for a particular person based on their own presentation. In the context of your work as a physio working in this space, could you briefly give a bit of an overview? I mean, it's going to be very different from person to person, but what are
Mhm.
some of the things that we're sort of thinking about in terms of management for these folk?
Yeah, well, there's management, there's physiotherapy management, and then there's coordinating care to get people other management, I think, are the two main roles. I think from a physiotherapy point of view, we tend to look at functional assessment. So looking at the way people walk, get in and out of a chair, stand on one leg, lift their arm, and what muscles they're using, rather than looking at broad terms like strength. We're more looking at things like motor control, efficiency of movement. So I can often very clearly assess, when I see what muscles someone's using to stand on one leg, that can give me a bit of an overall treatment plan. So I know that if we can improve that ability to transfer load from one leg across the pelvis to the other with walking, then that's going to help things
Mm.
when you're upright. So because it's very easy as a physio to end up in a little bit of a zoomy chase around the body, trying to treat whatever the new thing is. And I recently went to a physiotherapy conference, and they were saying that, an acute shoulder rotator cuff issue, you should have 8 sessions in the first 6 weeks is the best course of outcome. And I was just trying to see how that could work for our clients when they have an acute shoulder dislocation and a subacute knee and chronic back. You'd have to be at the physio every day to have each joint treated the way it needed to be treated if you were a normal person who just has a sore shoulder. So I think that's where a lot of people get overwhelmed with trying to give people everything they need in a short time. So I think you have to prioritize, in regions. So I would say, all right, someone's complaining of neck and headache. I would prioritize the head to mid thoracic region for my assessment, and trying to pick out those things that seem to be contributing from a movement or postural position, that modifying helps those symptoms. And yes, people love hands-on, and we definitely do it 50-50 in our clinic, but I think you have to sort of look at it as a region. So if someone's got hip, knee, foot, and shoulder pain, I'm going to low back down as my region, and then probably single in around the hip and pelvis and core as a starting point, because I think that's always a good fallback position to start. Because if you don't have appropriate weight shift and appropriate core activation in an efficient manner, which isn't gripping and holding your breath, then it's very hard for the pelvis to stack over the rest of the body and very hard for the rest of the body to stack over the pelvis.
Mm.
So sometimes with people with really sensitive necks, we still start around the hip and pelvis. So for me, that's where I would start. As far as other management, once we've done our screening, if there's any possibility of any of these other conditions, we might get the GP started with recommendations around an echo scan or a ECG just to get some basics. And then I usually go for POTS as the first low hanging fruit and coordinate with the GP about adding salt or electrolytes to people's diets and compression, because often those conservative management ideas make a huge difference. If that's not enough, we go to a cardiologist, and then we can start going through some of the other ones. With gut, it's very helpful for conservative management of MCAS to be started, reducing irritants in the environment. A lot of people already know what their irritants are. They're just avoiding it. And then usually a referral to some dietitians and to look at diet in that case is extremely helpful. The other thing for the gut that we like to do, I mean, I could go on for hours, Sophie. Gut stuff as a physio, my first step is pelvic floor control and pelvic floor overactivity, giving people advice about, good ways to go to the toilet, simple things like there's so many different things within physiotherapy scope that we can do. We can even do a NASA lean test to determine if people fit the POTS criteria and then send that with our letter to the GP. So we're using the best practice that I'm sure Mary Claire talked about to help them with those things, because let's face it, the GPs have 10 or 15 minutes. They don't have time to do all this stuff. So I do believe that I do try to guide where I can with helpful information, and usually it's received well because, everyone just wants to help their patients.
100%. And I think, as with all of these conversations in any area, it's always about, for you as an individual clinician, knowing where your own knowledge, competency, scope of practice sits. And that's going to be different depending on your skill set, your experience, your settings, your training, all that thing.
Exactly.
So, of course, that caveat. But I agree. I think, we're often in quite a good position to be able to be aware of all of these different overlapping complex things and to kind of pick up helpful elements that might help potentially guide treatment. And I find it really interesting because clinically that's a thing that we see a lot. You mentioned that tendency sometimes for people to present in a very sort of antalgic, gripping, guarding, everything's just on and intense, because that's actually quite opposite to what most people assume when you're talking about hypermobility, right? Most people have the gangly, everything's just loose and lax. And certainly sometimes you'll see that, but I think probably in my experience working in that sort of pain space, quite often it's the opposite, and people might actually be quite tense and locked up because it's just that sort of protective mechanism and their body's trying for dear life to hold their joints together with their muscular activity. So I've found in my practice, one of the first things I'm doing with people is actually, rather than jumping straight to strength work, sometimes it's actually about the opposite and going, we actually just kind of need to get things to calm down a little bit. It might be some trying to do some like sort of muscle relaxation or retraining that allows them to use those muscles more appropriately. It's such an interesting space. But do you find I know that you do, but just to kind of articulate it for people that are listening, in terms of sort of other supports, when we're thinking about the musculoskeletal component of hypermobility and the fact that often people are presenting with a lot of functional instability, in terms of the use of sort of augmentative bracing supports, that sort of stuff, do you find that you're often looking at that with people?
I love it.
Yeah.
I think it's a great idea. And I think that, again, there's a little bit of stigma around the use of braces and supports due to the possibility of becoming reliant on those supports. And I think that that is always a discussion we need to have with clients to let them know the appropriate way to not become reliant on a splint. But I sort of think about it as a traffic light system. So your red light splints are the things that you're most likely to become reliant on. So they tend to be the splints that completely completely stop movement in one or more joints for a prolonged period of time. So think about if someone's got a cast on or a brace that doesn't let their wrist move at all. It interferes with function. So that's what you're using in those acute periods after a dislocation or a flare to give your joints a rest to settle. And then there's things like the amber light system would be those splints that control some of the range of a joint, but not all. So for example, there's like little thumb splints that stop your finger doing the hyperextension range and keeps you here and still allows this movement. They can be helpful, and they're unlikely to cause, they may cause reliance because it feels so good not to have your joints doing that.
Yep.
But also things like, dynamic tape, which is stretchy tape, K-tape, body braids. There's lots of elasticated type things. And even things like soft collars. If you put a soft collar on someone's neck and then they're able to get out of bed, go to a cafe, walk around and help their kids, there may be some potential reliance of the neck muscles, but because you're using the shoulder muscles and moving back and forth, a lot of those muscles are still going to be used isometrically. So, which is just they contract in place. So we just give people a little exercise program so that they can make sure every hour they're either coming out of the brace for 15 minutes or moving around to prevent that issue. And then I think your green braces are probably things like compression tights and tubey grip, those sorts of things that improve your proprioceptive feeling, may provide a little bit of stability, but they don't really change how the joints move.
Absolutely. And I think you've articulated that really well. And the kind of controversy almost around splints and braces is something that I've often found, because coming from the pain space, often the focus very much has been, no, we want to get people active, moving, exercising, and
Yes.
the risk of kind of people becoming reliant or sometimes unintentionally sort of promoting fear avoidance sometimes by using braces. I think that's an important conversation to have. But I agree with you. I think, it has to be based on the person and what is the utility of this particular thing for this person. So I
Mm.
certainly wouldn't whack everyone in a splint or a brace or anything. The goal, of course, is always to try and optimize their intrinsic capacity for control
Mm.
and function.
Mhm.
And we're still
Mhm.
giving them exercise programs and looking at building that strength and range and control. But there's many people for whom actually having one of these devices can make a huge difference to their functional capacity, to their ability to engage, to their symptom levels, so that they're actually able to more effectively engage in some of their more active rehab. I think why would I not do something like that if it's going to make a massive difference to their quality of life and their ability to be active and do the things they want to do? It's
Yeah. I mean,
such
I look
an
at it at the same as people wearing orthotics in their shoes. I mean, this provides people with a lot of relief for their pain. And then I just sort of say, well, make sure you have some time without them. We don't want to be in the point that you can't go on a walk on the beach for 5 minutes because you're scared of your orthotics coming off. So, and I think not using braces is a bit cruel because if you have a 45-year-old guy present with his first shoulder dislocation, he'll be put in a locked brace for 4 to 6 weeks sometimes, or a severe ankle injury will be put in a moon boot. Just because someone has had lots of joint issues in the past doesn't mean we should just go toughen up, you don't need it. I
yeah.
mean, like, so so
Good
I think
point. It's funny, isn't it? It's like, oh, you're only allowed this for, 3 months and then that's it. We're off everything.
yeah.
It's really interesting. I've never thought of it in exactly that way, but I agree totally. And that's often the effect of what we see. And I think, there is a difference, I think, when we're talking about certainly I guess the underlying sort of type of presentation. If we're
Mhm.
looking
Yeah.
more at the pain space more generally, and we're working with people who might have predominantly nociplastic pain without as much tissue involvement, for sure, we probably don't want to be, I guess, over focusing on tissues where there isn't specific tissue pathology going on.
I think sometimes you can have a chronically injured joint with an acute issue on top of it. And
Absolutely.
so, I always think about, a hypermobile joint, like a joint that subluxes 20 times a day. If it comes out easy, it's probably going to go back in easy. But for example, I had someone the other day who's been dislocating their patella regularly for years, but they had a fall and did a forced medial patella dislocation. So it's also the direction of the subluxation or the instability that we have to be aware of.
Because it's like, yes, this pain is chronic. And the dominant way of thinking about chronic pain is, oh, it's predominantly nociplastic. But
Mhm,
really, in this cohort, we're looking at people who have had chronic and prolonged nociceptive input from joint
mhm.
trauma,
Yep,
musculoskeletal loading.
yeah, yep.
But and I think that's from coming from the pain space, that's also the really interesting thing in my work, I think, because 100% we are looking, we don't want to miss those tissue-based factors in this group, because there's some really meaningful, helpful management that can be done when we explore those issues and help optimize rehab that way. And then I think the beauty of it is, it's not to say, I think we don't have to be either or. And the reality is, a lot of pain presentations are mixed mechanism. There's usually a combination of nociceptive, neuropathic,
And
nociplastic.
actually, and I think the thing with those with who are hypermobile, it just depends on the way you bring it up. And
Right, definitely.
I think it's more about, for me, talking through, mechanisms, pacing, graduated loading. I think we actually agree on all those things.
Absolutely.
It's just the way, I think, having been around pain for a long time, they sometimes are a little bit triggered by some of those discussions. So I think we tend to try to develop the rapport first, notice the effect of the localized and regional treatment, try and get some of the loading off the joint that may be causing some of this extra trauma, and then see where we are. And then just, slowly bring it into conversations about
Absolutely.
pacing. Because a lot of hypermobiles, as we didn't really discuss, there's a higher proportion of ADHD and autism in this group as well. So, not talking about anyone in this room, Sophie, but
Neither of us.
of us ever would tend to do more than we really had the spoons for. Tend to just go and go and go until we crash. So trying to learn that to listen to your body and take those signals before the body has to flood you with intense pain is part of that learning how to cope with a hypermobile body, because it's not like you go, I got over this injury, I'm never going to have to pace again. It's a lifelong change. And I think once people are at that point that they understand that some modifications is going to make their long-term life a lot better, I think that that's when the physiotherapy can really thrive. I think when people are still in that lacking of acceptance of where they actually truly are, I think that's when we really struggle to make an improvement that's significant enough, quick enough for people
Mm.
to see, like their brother would do who isn't hypermobile, comparing themselves to a normal tissue person.
Yeah. And I actually really appreciate that, coming from, sort of more of the musculoskeletal camp of things, that sometimes it can feel difficult because it can feel a bit factional, musk versus pain. It's, you go on social media as a clinician and it seems very heated and polarized, and there's all this thing. But I actually, like you said, don't think that there's as much that we disagree on. And I think most people actually really land in the middle. I think for me, coming from a pain background, I've done, pain title, done all the pain training. I was a pain educator. So I'm very, I would say, quite informed in that space. And I can see that there is so much value in a lot of the skills and a lot of these strategies that we use in pain when we're working with this cohort, because so much of pain management is about, let's look at the big picture. What are all the things that are contributing and how can we optimize these different components? And we know for the group of people we're working with, that's really needed because things are so complex. But at the same time, I can have firsthand seen from experiences of people who are hypermobile or have these overlapping conditions that our traditional pain management approaches and services have not usually been particularly aware and not particularly sensitive to the unique experiences of people in this group. And I've certainly seen a lot of people who have seen very well meaning clinicians who have been left feeling invalidated, who have had, suboptimal management, not because the pain management side of things was necessarily wrong, but because it was kind of missing that picture of that
Yeah.
added layer of tissue stuff. And I actually think when you look at how a lot of pain education and the science is being taught now, if you actually go and do that, the actual models themselves do really accommodate for tissue based contributions. I think it's more about, sometimes it hasn't been applied in that way particularly well, and it's been maybe over psychologized or over
Hmm. Yes.
put in the brain and
Yeah.
sort of separate. And I think most very good clinicians who are working in this pain space that I know fully recognize and appreciate that everything's in the picture. We need to accommodate the tissue as well as other stuff. So it's kind of sad to see that it's been that factional, but
I think that's the same. It's everything that I've seen in physio sort of go. I've been around for nearly 30 years now, and it does tend to ebb and flow from one sort of fad to the next or system to the next. And this is going to be, this is going to be the answer. And then, so it usually comes back to the middle. And I think we're swinging back to the middle a little bit with it. It's a bit like core training
Mm.
has quite a negative connotation in a lot of circles. I totally understand that because most of the work I'm doing with people when I'm training their core is teaching them to let go of their
yes.
core and learning to trust their bodies, that when they let go of all this overactivity, that I can show them that their core is working very well when they're relaxed, when they're in a nice mid position, and that we don't have to think about. The first thing I do with everyone is going when they talk about their core is I'm going, do you walk around trying to pull your core on? And they're like, all the time. I'm like, well, stop that forever
Yeah.
because there is no need. Every now and again, like post-pregnancy, every now and again, and certainly people with like maybe SIJ instability, we do revisit it from a functional cross control across the body, but it has to be moderate. We're not talking about doing, overhead presses on a gym ball. This is learning to listen to your body, remembering how to breathe again and letting tension go. So when I say I do core training, it's probably core untraining.
Yes.
So, but I think words and social media and memes come up and people post things like, if you're ever looking at the core anymore, then you should be cast out of the physiotherapy profession. And I'm just like, wow, like it's just not that simple. It's there's bits that we can get from everyone. And that seems to be what people get when they come to our clinic, is just a very calm overview of a lot of stuff and validation. That's all we're really doing. It's not, everyone's like to me, what do you do with this? And it's like, it's just physio. It's not fancy. It's just slower
Hmm.
with less expectations of the speed of recovery.
Hmm.
I mean, that's all it is. So if there's people out there going, they've been treating someone's ankle for 6 weeks and it's not getting, their sprain isn't better yet, there's no need for surgery if they're hypermobile. Sure, get a consultation if you need to, but give it 3 months. I've met so many patients who are doing well with their physios who just cut off treatment because of some arbitrary number of weeks that it was supposed to be fixed by. It takes as long as it takes.
When talking about some of the work that you do, a big part of it is about getting people more confident in their body. And that's a really strong thing, I think. And actually, I think if you ask any person who's coming from the pain space, that's at the core of what we're trying to do, is like, how do we kind of reduce, not that every person with pain is inherently fearful, but when
No,
fear is there, how can we reduce that? How can we help build confidence in your body? And how do we get you experimenting with movement in different ways that sort of
absolutely.
helps to build that self-efficacy? And that's at the core of what you're doing, right? That's the same. And I think it touches on that really delicate issue of how, yeah, I guess making sure we're threading that needle of, we want to recognize that there are these specific tissue-based factors going on that are influencing someone's capacity, their symptoms, all these things, and can be amenable to treatment, while also making sure that we're doing it in a way that isn't promoting fear and avoidance and sort of, setting them backwards that way. And that's a really tough needle to thread, but I think you've captured that really nicely and how you've explained that. And I know you mentioned you use the kinesiophobia
Yes,
elements in your intake as well. So it
yes.
sounds like that's something that you're sort of quite conscious of when you're doing your assessments as well.
Absolutely. Yeah,
Yeah.
yeah. Yeah, we are. And I think surprisingly sometimes it's just those little things that can make a big difference, because if a joint isn't injured, but it aligns in such a way when there's weight through it that more weight's going through one side of it or another, if we make some changes. So if I know tape doesn't change alignment, but perhaps tape facilitates muscles, right? So if I tape someone or hold someone or help them move as a treatment direction test and that pain decreases, then I go, great. Now what we have to do is teach your muscles to do that. Or that feels great with that tape on or that brace on. Okay, that's to get you through while we learn for the muscle to hold your shoulder where it needs to go.
Yep.
Do you know what I mean?
Absolutely.
It's just back to basics. It's not really that tricky. We just sort of got a bit some therapists, we got a bit lost in the complexity of everything. So I think what I'm trying to ultimately with my courses teach people is rather than be scared of hypermobiles, that they're fragile, give them the tools that they need to be able to move forward. Find the simplicity and the complexity for them so they can have a path. I think that's the most important thing, because just because, someone comes up with slightly stretchier skin than you thought should be, so maybe they're classical, please don't discharge them. Please don't tell them to go find a geneticist and wait 2 years to see someone to be told if they are or not, because in the end, they still need to come back and be managed. Modify your treatment so you feel safe, get the help that you need, and continue to help them.
We're doing heaps of amazing work, and there's a lot that people who are looking to learn more in this space could kind of go check out. I'm wondering where can people maybe find more information about the work that you're doing, or what would you recommend for people?
So for clinicians, the health professionals, doctors, I'd suggest you go to hypermobilityproject.com. That's the clinical arm of teaching that I'm working with. I've just had my first full cohort through our diagnosis and ethics masterclass, and it was amazing. It went really well. And the next one, we'll probably run that again this year. And then we're hopefully, depending on how much I can overload and not pace myself, I'll get the second course out, which will be the comorbidity and co-occurring conditions one. Now on there's lots of free stuff as well. So under resource packs, how to try and set up an MDT, all the directories, a lot of the free toolkits that are out there, some articles, links to the spider. So there's lots on there for people to go have a look at. And then over on Not Just Bendy is more our site for patients. And on Not Just Bendy, there's a resources page as well. And it's got a lot of links to all sorts of different things to learn more. So that'd be your two big ones I'd go for if you're looking for more information.
Yeah, fantastic. And just as like very general resources as well, definitely the Ehlers-Danlos Society has a really great website with lots of stuff, and that'll be probably a good place to suss out the announcements around the new clinical criteria,
Yes.
which I'm very excited for. I feel like we need a bit of a betting pool or something going on as to what that's going to look like. I feel like there's lots of ways it could go, and I'm very interested to
Well,
see.
I'm hoping I'm going to get the lowdown in LA next week when I head over, but we'll be sworn to secrecy if they do tell us. So we'll. I think more importantly, it's going to be the publications that are going to be published a year later with clinical frameworks. So that's what I'm really interested to see how they're coming up with that information as well.
Absolutely. Well, look, thank you so much. That it's been really great. And between what we've spoken about and those resources, there will be heaps. And just as a side note, too, I was lucky enough to get a bit of a sneak peek at Sharon's course. So thank you very much for sharing that with me, Sharon, because I was very keen. And I've had a look through. Content is fantastic, and I would really recommend it for anyone who's interested in doing more in that space, because yeah, it is fantastic. So definitely consider it if it's something that you're interested in learning more about. But thank you so much, Sharon, for giving up your time and your expertise to come and join me today. I always enjoy a chat with you, and it's nice to be able to do a bit more formal setting so that others can sit in and learn from your wisdom.
Yes.
But thank you so much.
Thanks for having me along, Soph. It's been excellent.
Thank you so much. And hopefully we'll see everyone else next time on Beyond Pain and Fatigue. If you enjoyed this episode, we'd love for you to share it with a friend or a colleague, or maybe even leave us a quick review. Don't forget to subscribe so you don't miss any future episodes. If you've got an idea for a topic or a guest that you'd love to hear, definitely send us an email at podcast@vivepainfatigue.com.au. If you're interested in more resources or information, head to our website where you can find out more about our clinical services and our professional education. Until next time, take care.